Dr. Petro-Lize Wessels. She is a lead consultant in patient blood management and transfusion medicine at SANBS. She joined the SANBS in 2011 after 18 years in clinical medicine working across a broad field. She holds a BMedSc and MBCHB degree as well as a postgraduate diploma in transfusion medicine, all from the University of the Free State. She is responsible for medical support to and medical oversight and support to the processing laboratories and blood banks in SANBS, and is also responsible for driving the implementation of patient blood management in South Africa and on behalf of SANBS. She serves on the AABB Standards Revision Committee and the AABB PBM in Obstetrics Scoping Review Working Parties. She is one of the co-authors and developers of the University of Free State PBM short learning program for doctors and provided inputs into the course developed for registered nurses. She was co-author for an AABB textbook, Perspectives and Practices in Global Transfusion, specifically the Obstetrics chapter, and is currently working on an AABB textbook on education of healthcare professionals, specifically doctors training in LMIC's countries. I have no idea what that is. I'm sure you do. She's currently part of the Sub-Saharan PBM Steering Committee. She's going to be talking to us now about patient blood management, the South African story. Thank you and welcome.
Okay. Right. Thanks, everybody. It's truly the brave souls that is left. Either that or you don't have a social life, much like me. But either way, thank you for still sitting here. So 4 years ago, I told you about what is patient blood management. Then the next year I came here and I told you, okay, this is your ethical obligations and your legal responsibilities. Then last year I came here and I talked to you a lot about iron deficiency and where the GP fits into all of that. So after you've been listening to me since before COVID, I thought let me give you an update of how the story went in South Africa, what results we have seen after we started this in 2018, and what our obstacles are. So that is what we will be talking about. What is PBM? Just quickly a reminder, why do we need it? Factors that impacts on healthcare in South Africa, because that automatically impacts on how everybody out there can implement something like patient blood management. What as a blood service, looking at 8 of the 9 provinces in South Africa, what areas did we pick up of being of concern? And what happened in South Africa since 2017? And then some stats to show you whether we've actually been making progress, and then we'll be rid of me. Okay, so let's start. What's PBM? So in 2010, the World Health Organization declared PBM to be a basic standard of patient care, and that all measures should be implemented, all PBM measures should be implemented. Is this the light? Okay. And when you hear about PBM, you will always hear about the 3 pillars. So what is the definition of PBM? I like the SABM definition because they specify time. And they say it's the timely application of evidence-based. Not because we've been doing it in this hospital like this for 20 years. That's not evidence-based. That's inheriting it. Evidence-based medical and surgical concepts. The idea is to maintain your HB, minimize blood loss, optimize hemostasis, and why are we doing this? We want to improve patient outcomes. That's the whole goal. Patient blood management is not about using less blood. Patient blood management is optimizing your patient outcome. So, what's the core focus points of PBM? First of all, the patient has got their own red cells, some more than others, but all of them that's still breathing have some red cells left. So we need to, in time, optimize that, and we have to diagnose and treat anemia, and that's pillar 1. Pillar 2 is you have to control or minimize your blood loss or bleeding. Then you also have to optimize the patient's physiological reserves, because that relates to your patient's physiological tolerance to a low HB. And that is pillar 3. Then also it's very strongly focused on patient empowerment and patient participation in decision making. And that is where the whole informed consent stuff comes in. And most of all, PBM is multidisciplinary. It's not just the cardiothoracic surgeon in Bara. It's not just this woman from the blood service yapping about it. It's every GP, every nurse, every pharmacist who must make sure that there's iron supplementation. Every doctor, every anaesthetist, every hospital manager. It must be all of us. Okay. So why do we need PBM? That's the summary of why you need PBM. I love pictures. So let me explain my pictures to you. First of all, like Tab said, anemia is an enemy. We've got this common enemy and it creeps up on us because it's very silent. If you look at the publication in Blood in 2019, it will tell you that 1.2 billion people lives with iron deficiency anemia, IDA. And even more than that is iron deficient but not yet anemic. So the 1.9 billion is already at the point of anemia. Many more of them are not at the point of anemia yet. Very, very nice studies done by Betsy Lossoff and her group. They took a bunch of infants and they followed them up. They were all iron deficient when they entered the study. Then they followed them up until they were teenagers, and they went even further. They followed them up until they were about 25 years old. And what did they find? So all these babies that was enrolled was, number one, born to mothers that had iron deficiency anemia. So I'm going to show you a graph later on. Remember that iron deficient anemia mamas. 25% had iron deficiency anemia. Many more of them were iron deficient but not yet anemic. When they were teenagers, they found that they had learning difficulties, speech difficulties, issues with social interaction, aggression, discipline issues at school, and this was linked to the iron deficiency. As young adults, they never completed high school, they didn't have a tertiary education, they couldn't hold down jobs, most of them were single, so my family believes that's why I'm single. It's actually not iron deficiency, it's just my personality. Because they couldn't socially integrate and interact properly as a result of the iron deficiency. So really, this is a long-standing issue if you have a child born with iron deficiency. So what is your friend in this whole nightmare situation? Your friend is pillar one of patient blood management. You need to look for anemia. You need to manage your anemia, and you need to manage it properly. So iron deficiency should be considered a public health issue, and I'll show you why a little bit later. Going further, they did a very nice study in KZN at a regional level hospital at the on the antenatal mothers presenting there. Many of these mothers were seen either at an antenatal clinic and or a district hospital before they reached the regional hospital. 43% of them were still iron deficient anemic. The SASOS study was done in South Africa. Many of you will know about that. What did they find? This was elective surgery patients. You all know how long a patient waits in the public sector from the time that I decide you need your knee replacement until you actually go to theatre. It's months, if not years. So this was elective surgery patient. And by the time they got admitted for their surgery, 48% of them were still anemic. In other words, there was ample time to correct it, but the reality is nobody was looking for it, so it wasn't treated. They also found that your in-hospital mortality and your ICU was significantly increased in these anemic patients. I can stand here for 3 hours and quote literature for you that says the negative effects of preoperative anemia. You will have mortality, morbidity, increased length of stay, more ICU admissions, more infections, more exposure to transfusions, obviously, because you're anemic and I'm going to cause you to bleed. But what is the key recommendation? Your friend is, again, pillar one of patient blood management. You have to screen, diagnose, and treat all patients for anemia, You have to correct your pre-op anemia before the patient is admitted for surgery. And most of all, you cannot treat preoperative anemia with a red cell transfusion. It is just horrible to do that. Let's talk about transfusion risks, because the only risk-free transfusion is the one that you don't do. That's the reality. And yes, I work for the blood service, but we are open and honest about the risks of blood. So, the best summary I can give you comes from this international consensus group, and it was in 2009. In other words, this is not new. We've been knowing it for years. We need to start hearing it. What did they look at? Over 35,000 papers that was published, and they found a dose-dependent negative outcome. The more red cells you give, the more is the clinical negative impact on your patient. We are not talking about the patient where the blood is gushing out on the floor. When the blood is gushing out, you must put something in while somebody else is plugging the hole. Ne? But the majority of our patients, the blood is not gushing out on the floor. The majority of our patient is relatively controlled situations. So if you go over 3 units of red cells in those patients, you are actually harming your patient. Remember the 3. You will have mortality and increased morbidities, infections, deep vein thrombosis, ICU admissions, length of stay. The more blood products I expose you to, the more risk you have to have a transfusion adverse event. That goes without saying. Patient outcomes. Let's talk about optimizing patient outcomes. Beautiful study done in Western Australia over a 6-year period. They looked at over 640,000 adult patients. The second author of the study is Prof. Axel Hoffman. He also helped SANBS on our journey when we started with PBM. He's a health economist, which was very handy in the end. What did they find after 6 years? By implementing a restrictive approach and applying the 3 pillars of patient blood management, they found that your in-hospital mortality reduced with 28%, 15% less time spent in hospital, the bed is open for the next patient. Think about South Africa, access to care, our whole headache. 21% reduction in infection, 31% reduction in acute myocardial infarcts and strokes, and 6% increase in readmission. Why? More of them lived long enough to be readmitted. They didn't die in hospital on the first round. That's why they could be around to be readmitted. Another one was a systematic review that looked at 17 studies, about 236,000 odd patients, and 100,000 was before PBM, and about 130,000 was the PBM group. So what did they find? By implementing patient blood management, your transfusion rates dropped with 39%. Your red cell units per patient dropped with almost half a unit per patient. Do not underestimate that value. We're talking about millions of red cells. So imagine the reduced risk for patients. The length of stay dropped, the total number of complications dropped, and obviously the mortality rate dropped. So your patients do better if you apply PBM measures. Let's talk money. We're living in a very resource-constrained setting. Like I said, Prof. Axel was a health economist. So he was writing up all the money side of things while the doctors was writing up the clinical side. Now, when you look at the cost of transfusion, when I started at SANBS in 2011, I walked into a hospital meeting. The first question was, what do we owe you? How big is the blood bill? Because they thought that was it. That was the tip of the iceberg. The true cost of transfusion lies beneath the surface. It's your associated costs. It's your transport, it's your logistics, it's your staff training, it's your staff time, it's your equipment. Now your patient is going to have an adverse reaction to the blood product. Now you must treat that. And the patient end up in hospital longer. So you underestimate what transfusions cost you. What did the Western Australian group find? They found that the product, the blood bill, by implementing PBM, the blood bill dropped with 18.5 million over 6 years. However, the hidden costs dropped with between 80 and 100 million Australian dollars. So what am I telling you? Those of you who works in hospitals, take your blood bill, multiply it by 4 to 5 times. That is actually what transfusions are costing your facility. And that is very scary. And they invested 4.5 million Australian dollars to get the program running. That makes sense, no? So what is going to impact from where we stand, our interactions with hospitals? What do we see impacting on hospitals and healthcare in South Africa for that matter? First of all, resources. There is no money. There's not enough healthcare workers. You know how the interns and ComServes are sometimes sitting at home, only starting their ComServe year, middle of the year, because there wasn't a post available for them. And less doctors means less people to care for our patients. Ne? When we listen to the big public hospitals sitting on the provincial meetings, their big problem with their budget is the budgets are determined by the population that they are supposedly serving. But what about the foreigners, the migrants? They are not calculated into that budget because they are not counted as in our statistics of population. So they are always having a budget deficit because they've got these extra patients that they care for. And I've read a report from one hospital where they actually estimate in the obstetrics setting, 40% of their patients are not South African nationals. So they are already with a 40% backlog on their budget. There'll never be enough money. We also know that the worse the economy goes, the more people let go of their medical aids, meaning those people now become a burden on the public sector even more. And then you've got this thing of, this is best practice, this is how we must do it, but the reality is, what can South Africa afford? And those two things are not even in the same chapter of the textbook. So as far as donors and patients go, the more you have iron-deficient donors, on top of the poor socioeconomic circumstances, on top of the fact that we've got this burden of disease, thinking about HIV, etc. in South Africa, now you're bringing in this whole poorer health state of donors. Where are we going to get donors from? If we don't have donors, we're going to get blood for the patients because the population keeps growing. So that is the problem. As we are upgrading some hospitals, and we are truly seeing that a lot of good work is being done, we see that access to healthcare are improving. But the moment that happens, the blood demand is going to go up because there's more people getting to a doctor who can actually make the decision to prescribe the blood product. Now, let's talk about the world out there. We know that when we buy consumables, it's very often from overseas, and the exchange rate is killing South Africa at this stage. It's a reality. We also know that there's a delay in accessing consumables. Supply chain issues. Who of you working in the public sector has heard the words supply chain issues? So you've got a delayed access to actually take care of your patient. And every time something happens and there's sanctions or whatnot, then it affects us greatly. We have seen, working with 8 provinces, every time there's a change in government structures, you find that your provincial structures change, meaning that your management in public hospitals change, meaning that the program doesn't have time to run its course and to get well rooted in, and then the hospital manager changes again. So it's very difficult to get something growing in this culture. NHI, it's beautiful. I fully believe in NHI. But how will it be funded? In what format will it be implemented? How is it actually going to affect the way we care for our patients? Then you think about civil unrest. Now the patients can't get to the clinic, they can't get to the hospital. The donors can't get to the donation sites. My blood bank staff can't get to the blood banks to actually do the cross-matches and issue the blood. It's a big thing. And how is the regulatory changes going to affect this whole picture? The reality of infrastructure. What are we going to do if we don't have power? What happens to the hospitals? Their generators are old. They don't have diesel. How big parts of the hospitals are left without electricity and now recently often without water? This is practical realities that our doctors and our nurses must face out there. We want to do everything electronically, but that means the IT systems must be compatible with all the service providers, whether it's SANBS, whether it's NHLS, whether it's Lancet, Ampath, what it may be. So do we have that infrastructure available? Can we go there when on the ground it's not possible for our colleagues? Skill shortages. Do we have IT staff? Do we have enough doctors? Do we have enough nurses? Do I have enough technologists who can do cross-matches in blood banks? And the answer is no. And then our facilities are aging. These hospitals need upkeep. They need maintenance. They need repairs. Where do I go with my patients while that is happening? This is the realities against which SANBS is trying to convince the healthcare sector to implement patient blood management. And we expect them to make it a priority because it's really good for our patients, no? But they have to live with this every day. So a couple of areas of concern for a blood service is access to products. We want it equitably distributed and the concept of distributive justice, which means scarce resources must be equitably distributed, and a patient should have the same care for the same condition, irrespective of where they present. That is distributive justice. Scarcities of donors. Every time I bleed you, I take some of your iron. We need to take care of that. Otherwise, we're going to run out of donors. And blood products is already scarce as it is. The risk associated with transfusion, it's not per the transfusion, it's per the product. And some of the stuff we do in hospitals to these products cause the adverse events. And then the inherent risk to transfusions that we already spoke about. We have to optimize patient outcomes, BBM principles. We need to educate the patient, the public, not just the doctors and the nurses. And then also in the background, the poor doctor and nurse must not forget about what the law says and what the council expects them to do on an ethical front. So these guys are truly overwhelmed out there. It's a bit much. Very beautiful presentation. And I told you, remember this distributive justice. This is red cell issues, male, male, female, female, private sector, public sector. If you look at that picture, what do you see? You see a pregnant woman, ne? Meaning in the public sector, it's very clear where the red cells are going. So my question is that not indicative of the poor antenatal programs we have in South Africa? And the fact that when they present to deliver their babies, they're already so anemic that normal blood loss pushes them into decompensation and they end up needing a transfusion. Because we're not seeing it in the private sector. It's a flat line. But clearly something's happening to the women of childbearing age in the public sector. Just some more. If you look at the per capita use in the public sector, around the 11s, 12, private sector 34, 38, 36. Doesn't mean that our private sector colleagues are wasting blood. It's got to do with access to care. It's got to do with there have to be a doctor available to prescribe the blood. That's not equitable distribution of healthcare resources. No, it shows you it's not. And then also that has now increased to about, that has now increased to about 12 in the public and 40 in the private sector. The gap is growing. So the biggest concern of all for SANBS is the fact that doctors and nurses and often hospital management doesn't realize that their knowledge is outdated or not sufficient, and that there's no national governance or oversight over something like the iron deficiency problem in South Africa. So what has been happening in South Africa? September 2017, Prof. Axel Hoffman came to visit SANBS there in Roodepoort, and we started on the journey. February 2018 was the first, at that stage it was the South African PBM steering group and interest group meeting in the Cape Town, and we published in the SMAJ, and we call it a call to action. August 2018, SANBS decided they're going to allocate full-time resources to driving patient blood management, and that's where me and my department was established. And by the end of 2019, through very painful processes, we established our recipe of how to drive patient blood management, and we refer to it as our flower power. And flower power for us is education, giving good quality reports and stats back to a hospital, really building the relationship with our stakeholders, including events like this, and having discussion platforms where we can talk about blood. But we also realized that we need to take care of our donors, and the fact that we do an HB only might not be good enough for our at-risk groups of donors. And we started to implement ferritin testing for our donors based on an algorithmic approach for certain at-risk groups. So SANBS helps with training nursing staff, training doctor staff, supplying reports, whether it's per facility, per province, whatever the case may be. We participate in their discussion platforms, and whenever somebody wants a policy reviewed, SANBS is happy to provide inputs and support there. But we are not forgetting about our donors. We also have a very well-run donor wellness program to make sure that the donors are safe and not harmed. We have continued professional education. We've got the short course that Tabiso referred to. We've got a lot of undergrad programs. We've got the HEM deep dive and the gastro echo that actually covers the whole of Africa, not just South Africa. We have been included in SAMA. We've been included in all the private sector groups, academic programs. We have our own virtual learning program, very efficiently run by Tabiso. And then we also have that same platform where external healthcare workers can get their CPD points. We have discussion platforms, whether it be individualized, provincial, or national. And in the private sector, we try to support on a per hospital group basis, but then also on individual hospital basis. We know that you need help, so we've taken our knowledge and we've put it to paper. The new clinical guidelines that was published last year now have a chapter on PBM. We've got what we call the nurses guideline. We've got an intern orientation program. We've got an emergency fridge book. We've got a little booklet telling you how to use SANBS stats to monitor your program in your hospital. And we've got lots of infographics and material that we distribute electronically. So did we see any impact? Very long introduction to answer the question. Eh? So did we see any impact? Don't worry, it's organized chaos. So remember we said patient blood management. Now, if you go and read literature on patient blood management, it tells you that a patient between 7 to 8 is that bracket of patient where you need to apply your clinical judgment because it's not actively bleeding patients. Once you go over 8, patients are not really supposed to be needing blood, with a few fairly scattered exceptions. Yet if you look at the public sector is yellow, private sector is yellow, public sector. Year on year, from 2019 to 2023, there are certain provinces that remain above 8. They should wonder about their decision-making process. Remember I said negative clinical outcomes, especially if you go over 3 units of red cells per patient? All of those, year on year on year, are exposing patients to more than 3 units of red cells. So that is the total number of red cells that a patient is exposed to. It is above 3. We should be worried. But it's not just all doom and gloom. The other thing we monitor is whether the culture is slowly changing. And how do we monitor that? By what is the doctor's first inclination when they order? How much is on a request that they send us? Not how much the patient receives in total, how much is on a request? Have I changed my mind to start ordering less at a time? So you will see Gauteng definitely in the private sector shows a decrease. The culture is changing. Same in KZN private, same in Mpumalanga private, same in Northwest private, same in Free State public, same in KZN public, same in Limpopo public, Mpumalanga public, Northern Cape public, and Northwest public. So the cultures seem to be changing on how many am I inclined to put on a request form at a time. Now the number change might look small. Keep in mind we're talking about 1 million products a year. So even a second decimal change is an actual change for patient. So truly not only doom and gloom. The other thing we look at is called 1 unit at a time requests, because that is a principle of patient blood management. Your patient is not actively bleeding, you order just one. You look what your patient looks like after the unit, and then you decide. So to be fair, I can only assess that if you've got 24-hour on-site access to blood. No. Otherwise, it's an unfair assessment. There are 37 hospitals that qualify for that, 7 in the private sector, 30 in the public sector. So we don't monitor issues, because if we don't have blood, we enforce cutbacks. So it will be artificial. We monitor what you request, because that tells me about your ordering culture. We also did surveys last year to determine what hampers the culture. And the feedback we got was there's not enough doctors to go back and reassess that patient for the second unit, so we just ordered 2 units from the get-go. So what does the stats look like? If you look at, so the reason why we take the period Jan to June of each year is simple. All the new interns starts in Jan. So it does take time for them to kind of get used to the culture and the ordering and the SOPs in our hospital. So we take Jan to June of each year, and we followed it up from 2018 onwards. You will see that there's been a 4.4% increase in the culture of only ordering 1 unit at a time. You will find that the private sector is still a bit lagging behind. Remember, all of them have the same access to blood products, ne? So they're a bit slow on the uptake. Remember, 2020 was COVID. And you will find that the public sector, because they are the major user of blood products, mostly determines what the blue line, the SANBS picture, would look like. We've also found that there's a discrepancy between private and public, but there's also a discrepancy between provinces, and we can link that discrepancy to how well certain provinces open to us for training, for discussion platforms, asking inputs into policies and guidelines, and that is directly linked to the picture we see. So if you look at private sector, you will see that KZN struggles, but there's only 1 hospital in KZN that qualifies. So it's a single hospital that we're measuring. Free State seem to be doing good, but not bragging, guys. I'm from the Free State. We've been doing PBM since 2013 in the Free State. We started years before South Africa started. So, and then Gauteng is really picking up very nicely. Okay? If you look at the public sector, it looks as if, wow, look at the Northern Cape. Man, what a bunch of overachievers. There's only 1 hospital in the Northern Cape that qualifies. So again, you only have to get your message to 1 place, not 25 places, like the case of Gauteng, which is the grey line. But even Gauteng is showing a very nice pattern of increasing. Okay. So always be careful of the background information when you look at a graph. So overall, statistically significant increase in the culture of ordering 1 unit at a time. So it takes a lot of effort. That little bit that you can see there, that's what you think you're seeing. What the world is not seeing is all these battles that the hospitals and the doctors and the nurses and the public and SANBS is fighting. We've come a long way. We are very proud of what we've achieved in South Africa. We've got awesome, awesome partners out there in the world of clinical medicine. We couldn't do a copy and paste from the literature because guess what? Our healthcare environment doesn't look like the literature's healthcare environment. The blood services kicked off in 2017, 2018 to be the bus driver, being the GPS, being the person keeping everybody on the bus entertained, just doing everything around it. We are very fortunate to report that we're seeing a shift. We're seeing the clinical community in South Africa stepping up and taking up their rightful place to drive PBM. And this gives us the opportunity to step back into a supportive role to help them drive PBM. I think it's probably the only country in the world where the blood service started PBM in a country, where the blood service doesn't see PBM as a threat, because we realize there's never going to be enough blood in this country. And if we don't do PBM, and if we don't address iron deficiency, patients will die. The little bit of blood that we do have, we need to make sure it gets to the patient that really needs it. Thank you very much.
Hi. Yes. I want to know, when are we going to start testing for iron levels in babies? Okay.
In babies.
Yeah. There's considerable evidence that a lot of neurodevelopmental delays are caused by anemic babies born from anemic from mothers.
Yes, the loss of studies. Yeah.
And even some psychiatric illnesses.
Definitely. That's why I quoted Lossof's work. It shows exactly that, the teenage issues and even into early young adulthood. So when should we start? We should have started yesterday. When will we start? You're asking the wrong person. I'm just the lady sitting in the blood service trying to get everybody enthusiastic about doing the stuff. That's why I made the statement early in my presentation. Iron deficiency should be seen as a public health issue. So I hope every time I speak to a group of professionals, the voices grow, and the louder we can speak, and it will ultimately reach the right ears, that it's given the attention that it should be getting. But if you ask me when we should have started, yesterday already.
Any other questions? I think one thing that struck me when you said at the end about, the only country that was implemented, it shows an example of how, we think of it, although it's a commercial product, at the end of the day, doing good for everyone actually does good for everyone. You can't only think about, if you were selfish and just thought, well, more people just need to order blood, it doesn't help in the end, because if you have less blood available, it's not going to serve you anyway. And I think that's probably a lesson in private practice as well, that better outcomes for your patients actually is better business sense. But I just want to thank